Hello and welcome to ID Talk, answers from an infectious disease expert. I'm Dr. Sean Elliott, a pediatric infectious disease specialist with Tucson Medical Center, professor emeritus of pediatrics at the University of Arizona College of Medicine, and medical director of infectious diseases and immunizations at the Arizona chapter of the American Academy of Pediatrics. This podcast has been created to answer questions from our chapter's members about the COVID-19 pandemic and pretty much anything else which might come to our attention. So this is the week of August 7th, and once again, some great questions, getting back to some stuff having to do with COVID, but also some very interesting and out there questions. First of all, a brief update on our dear friend SARS coronavirus 2 and what's happening. We are now emerging into the next subvariant of COVID-19, or Omicron subvariant, this being the EG5 variant, codenamed Eris, E-R-I-S. So I guess that's a difference from Orthrus and Kraken, which have been the preceding prominent strains. So as of right now, the EG5 variant has been emerging in significance, accounting for over 17% of new isolates confirmed to SARS coronavirus 2 in the United States. That is now greater than the XBB.1.16, which is 15%, the XBB.2.23, which is 11%, and our dear friend XBB.1.5, or Orthrus, which is 10.3%. So even just a couple months ago, the .1.5 was the most predominant strain of isolate causing new disease in the state, and it has not been eclipsed by the others. What does this really mean? Not a huge amount. There's been no significant or discernible difference in infectiousness, virulence, disease-causing capabilities of any of these subvariants, and also and importantly, even though they represent mutational shifts from some of the original subvariants, immunizations against the XBB.1.5, which until recently has been the most predominant strain causing disease in the States, those new vaccines are anticipated to continue to provide plenty of protection even against the newest Eris, or EG.5. That's important because, yay, fantastic news, I guess, the newest advanced vaccines, mRNA vaccines from both Pfizer and Moderna, which cover now the XBB.1.5, are anticipated to be released pending FDA and CDC approval in late September. So, as anticipated, this may represent a change to annual vaccination against the most predominant circulating strains over the months preceding the fall, and anticipating that COVID-19 will continue to fall into, pardon the pun, a fall and winter-based infectious disease similar to respiratory viruses, and especially including influenza. So, you can anticipate, presumably in another 2 months' time, that we'll have vaccines coming to our practices and our clinical sites covering the XBB.1.5, which are very definitely anticipated to provide strong coverage for other circulating subvariants of Omicron which are out there. Not yet a word of guidance in terms of vaccine strategies from the ACIP or the AAP, but it is anticipated that a single dose of the new vaccines will be acceptable and immunogenic for those pediatric patients under age 4 who have not yet had any primary vaccine series before, and a single dose as a booster for those who have will also be adequate. Unclear what will happen, and of course that needs to be confirmed with official recommendations in terms of single versus multi-doses coming up. So stay tuned. I'm sure we'll cover that development or those developments further in this podcast as we get closer to September. So that is the update on COVID-19 in terms of what else is out there. We continue to see a fair smattering of respiratory illnesses. Yes, indeed, I imagine most of us have seen a small re-emergence of COVID-19 cases in our pediatric patients, including those getting hospitalized with respiratory distress, potentially related to SARS-CoV-2 or to other respiratory viruses. Still seeing, in fact, significantly still seeing some adenovirus cases out there as a source of fevers persisting past a couple days, fevers and rash, fevers and erythema multiforme, and also fevers and respiratory distress to failure, so pneumonia. RSV, rhinoentero have decreased in significance, but still a smattering of cases, and so far not yet huge numbers of influenzas A or B, but we can anticipate those coming in the near future. And along those words, in terms of influenza, you may recall we talked about a universal vaccine testing construct in this podcast several episodes ago. And this is an mRNA vaccine, universal flu vaccine, being tested currently at Duke in combination with CDC, NIH. And they are mid-test right now. I believe, if you remember, they were testing 50 recipients. It was mostly a dose escalation strategy to see what was most effective and what was tolerable. So still in the early phase 1 trials of this, but the initial mid-study results appear to be quite excellent. So I think there continues to be hope for a universal one-and-done flu vaccine using the mRNA strategy to a very stable component of influenza's external capsule structure and harnessing specifically the hemagglutinin stable component. So great news, and again, yet more for the future, and who knows a year from now what the world may look like in terms of vaccines and influenzas and COVIDs, et cetera, and so forth. But this at least suggests that we're heading in the right direction, so yay. Okay, to the questions. So, first one, speaking of COVID-19, is asking about a recent report looking at the prevalence of long COVID, or PACS, post-acute COVID syndrome as it's called, occurring in 16.2% of pediatric COVID-19 patients. And the questioner is asking, what are the manifestations as we now understand them for or from long COVID, and what should we do about the management and recognition of such patients? So yeah, this is, I think, an ongoing estimate, an ongoing study with long COVID, and as we get further into our experience with that this will continue to be fleshed out. As it now stands, if you look back both historically and also at sort of multi-center reviews, the risk of long COVID in a pediatric patient with known or antibody-confirmed COVID-19 ranges anywhere from 4 to 25%, depending on the series. Some of the larger series are stating that risk toward the lower end of that range, while smaller focused or pilot studies are toward the higher end. And so for the smaller studies, of course, you could imagine there may be selection bias, discernment bias, etc. But in general, I think that the most recent study or studies seem to split the difference, and around 15 to 16% of pediatric COVID-19 patients may or have been found to develop symptoms persisting past 1 month. And that kind of becomes the definition of long COVID. So define your symptom, and if it's there after a month, after a known onset of disease, then that counts as being long COVID or PACS. The classic long COVID patient, however, is still very much that of what we mostly see in the adult world. So it's going to be that individual who has most especially fatigue, malaise, so that I just feel terrible, I don't want to get out of bed, I'm so tired, very much along the lines of chronic fatigue patients and other similar entities that we've been dealing with since, well, I was in training a little while ago. So fatigue and malaise are probably the most two predominant or prominent components of long COVID, followed closely and perhaps associated by exercise intolerance, which is not just fatigue related, but may be related to cardiac function. And you may recall about 6 months ago or so, the American Heart Association and related organizations studied literature looking at the risk of myocarditis and specific cardiac dysfunction in pediatric COVID survivors, and found that to be a cause for concern. Note of caution in that there was definitely a subset population analysis in those studies. So they were looking at patients who had already had severe COVID, were already in hospital, and so may have had a higher dose of initial virus followed by a likely higher hyperimmune response. So that risk of myocarditis and specific cardiac dysfunction may not apply to all pediatric COVID-19 survivors, certainly the ones who are found after the fact who have had COVID-19. But regardless, the exercise intolerance is definitely a thing, and it would certainly go along with findings you might expect in a patient with a cardiomyopathy or cardiac dysfunction and myocardial disease. And then other signs and symptoms that one may encounter will be a persistent dry or non-productive cough, which some may attribute to the habit cough or a postnasal drip cough. And as I say that, of course, we all want to cough, right? So the cough is a thing, definitely the changes in taste and smell associated with either anorexia or decreased food tolerance, and then of course those patients who have unanticipated weight loss because they're not eating as much. Somewhat less prominently than in the adult world are the brain fog and memory loss. But that said, the patients that I have seen referred to me in pediatric infectious disease clinic, many of them find it difficult to follow along in school. So there is some sort of cognitive impact which they are experiencing, which seems to be more than you might expect for the degree of fatigue they're having. On the other hand, every single chronic fatigue patient that I've encountered for other triggering infections such as Epstein-Barr virus and coccidioides all have had the same thing. So I think we're seeing sort of just the typical syndrome of chronic fatigue, in this case due to SARS-CoV-2, and associated perhaps with an increased numbers of exercise intolerance, malaise, some with headaches, some with taste and smell perversions, and some with cough. So that is sort of the clinical symptomatology which we're encountering, and in pediatric patients lasting from 1 to 6 months. It is rare, not unreported, but rare for a pediatric patient to have persistence of long COVID symptoms past 6 months. And that actually can be used, sort of getting to the next part of the question, as part of the hope and the treatment and the management. And that is reassurance, empowering the patient to begin a slow, gradual exercise re-escalation campaign. So dealing with that fatigue by spending the first week just getting out of bed, sitting on a couch, and then the second week getting off the couch and walking around the house, and the third week getting out of the house and walking around the block once. And so sort of planning an exercise and writing it down on paper, or smartphone, but planning an exercise escalation campaign in combination with us as healthcare providers has been a very successful strategy to get the patients out of bed, out of the fatigue, and back into life and school activities. Providing hope, though, I think is perhaps the even better saying. So in adult patients, there certainly have been a subpopulation of long COVID survivor adults who have symptoms well past 1 year. Now, it is likely and in fact demonstrated in the literature that many of those adults have comorbidities, which thankfully in pediatrics we are less commonly going to encounter. So providing hope like, I know you feel terrible right now, you're 3 months in, but honestly by 3 months from now you're going to be okay. You're going to be back in the saddle, back to school, back playing, whatever, and it's going to be okay. Let's help you get back into the saddle by doing this exercise re-escalation campaign. So that is sort of both the recognition, the management strategies which one can offer. Along with that, for those PEDS patients who are suffering cognitive impact and also true exercise intolerance, our colleagues in sports medicine have been incredibly useful with physical therapy, with cognitive behavioral therapy, providing again a strategy and exercises which the patients can follow to get them back into life as they knew it. So I think have a low threshold to create a formal plan for exercise re-engagement, and certainly a low threshold for those with cognitive dysfunction to refer to behavioral specialists and or if you have access to your local sports medicine friend, referring the patients there. Certainly having a discussion with sports medicine about what they may be able to offer. There are no unfortunate magic bullets, although many have been tried in terms of medications or medical interventions for long COVID. At one point, it seemed that vaccinating the long COVID survivor, if they were or under-vaccinated, provided some benefit. Certainly that's not going to be harmful. It may be beneficial. And if it provides some sort of a placebo response, fantastic. Anything just to get the kid up and running. The medications, Paxlovid at one point was held out to be a possible positive intervention. So again, that combination protease inhibitor, which does have efficacy against active SARS-CoV-2 infection, but the limited studies looking at Paxlovid's impact on long COVID really showed equivocal results. So again, is there harm to that medication? Well, it's not a very pleasant medication to take. If anybody themselves has experienced that, they know that there's significant gastritis and nausea experienced by many people. And of course, these are two protease inhibitors, which are not without side effect profiles. Minor, to be sure, but it's not a risk-free intervention. So I at this point, again, this podcast is not about recommending interventions, but just letting you know what's out there. I would say at this point, the science does not support intervention with Paxlovid for patients with long COVID. And all the other fun things, antivirals, the hydroxychloroquines, azithromycin, none of those has been shown to have any significant benefit in patients with long COVID. So it's very much support, engagement, exercise re-engagement plan, and referring those patients with cognitive dysfunction to behavioral and cognitive specialists for specific interventions designed to increase their cognitive awareness. So great question. Thank you for bringing it up again. Certainly something which will continue to be experienced with, fortunately, not significantly high numbers. And as we get past our last major surges, hopefully the numbers of our pediatric patients who are still suffering from long COVID have dwindled. Yes, there will be continued mini surges. Certainly that is predicted as COVID-19 settles into an epidemic pattern, e.g. once a year during potentially the winter months, and I think we may be seeing that pattern starting to emerge this coming year or two. So stay tuned for more on that. Okay, somewhat related. Next question, and this question asks, cases of childhood type 1 diabetes rose in young people and others during the COVID-19 pandemic. Do we think that there is a direct impact of SARS-CoV-2 on type 1 diabetes cases? Wow, great question, and there's a whole bunch of scientific thought going into trying to answer that. First of all, what are the numbers? And yes, it is indeed true that monitoring many different organizations, including the endocrinologist at my institution and also the University of Arizona, we are partnering to study the same exact question. The numbers of new diagnosis type 1 insulin-dependent diabetes mellitus in pediatric patients did rise during the time period of the COVID-19 pandemic. And here we're including all three of the major surges, so the betas, the alphas, and the deltas, and to a lesser extent, Omicron. So the numbers did rise, even when controlling for other factors and looking at historical trends. This is significant. However, it is not 100% true or necessarily understood that the virus itself is doing anything to increase that specific rise. And in fact, in some small laboratory and animal studies, SARS-CoV-2 does not have specific tropism or favoritism for islet cells or pancreatic cells or anything else. But what is true, and I think we all are aware of this, is that SARS-CoV-2 is quite adept at triggering autoimmune reactions and certainly creating a hyperimmune response. Witness our patients with multisystem inflammatory syndrome in children, MISCs, and witness the patients in the early days, before we recognized this, that had severe multi-organ failure, respiratory disease, and death, all due to an uncontrolled inflammatory response. Certainly the virus and patients in the COVID-19 pandemic have had an escalation of hyperimmune and autoimmune diseases. And if you think of insulin-dependent diabetes as one such disease, it makes sense that that, along with others, would also increase in prevalence and incidence. What's interesting, however, is that other autoimmune diseases, and you might think of things like lupus or potentially rheumatoid or juvenile idiopathic arthritis or post-infectious vasculitis or Kawasaki's or all the other fun things which have something to do with autoimmune disease, those numbers so far have not been known to escalate. And certainly normal prevalence of RA and JIA should be sufficient that we would see an increase in those numbers if there was an upregulation from SARS-CoV-2 infection. So there was something about the interaction of SARS-CoV-2 and the endocrinologic hyperimmunity milieu that either at the very least allows escalation of disease process in a patient who's already likely to develop type 1 diabetes and or takes the otherwise sort of novel patient who is not at risk and does something to their immune system to trigger a reaction causing that. And both of those are sort of currently held hypotheses, and both are being explored very actively in the research world. So it's a fantastic question to which we don't have a very good answer. You can see what we do know in answer to this question summarized in a recent manuscript just released in open access Journal of American Medical Association Pediatrics. So JAMA Peds and JAMA Open Access carries this manuscript looking at a multi-center review and offering a discussion of those hypotheses and what we do and do not know. What we do not know is a lot, other than the fact that this association does seem to hold true and does seem to be valid. So again, I imagine as we get further into research results, I will hopefully have a better answer to this excellent question. Okay, let's change gears. Enough of SARS-CoV-2 and COVID-19 for a little while. This next one is having to do with a very common pediatric illness, i.e. molluscum contagiosum. And many of you may be aware that there's a recent FDA approval of a new topical medication, VP102 or YCANTH from the Verrica organization. And this is a formalized cantharidin product. Thank heavens, I know we've all used cantharidin or the blister beetle extract in various ways. Certainly in residency, our favorite dermatologists had their own secret little brown bottle hidden away, and we got to paint the tops of the molluscum warts and other things with a small Q-tip and the cantharidin and just watch it blister. And Oh, I did this with my poor daughter as well, grabbed some from a friend and brought it home. The challenge, however, and this is very important, is that all of those little brown bottles of cantharidin which we were using were completely unregulated and completely variable in terms of the concentration and the amount of actual blister beetle extract that was there. And there was certainly a shelf life of that extract. And so it may be that in some cases, and this did happen, some patients had incredibly extensive blisters in terms of almost like second and third degree burns, and that was not appropriate, versus others had a very minimal response and got retreated and then had something. With that experience, historically, the FDA was monitoring all the uses of these varying concentrations of cantharidin and eventually issued a warning about use of that. And so we've gone through a period where both commercially and sort of off the shelf, black label, et cetera, and so forth, we were unable to use or find cantharidin to treat all our patients with molluscum contagiosum. That now changes. And so this product, which has just been FDA approved, is the first of two that have been looked at coming down the pipeline. And this product specifically is a standardized concentration, 0.07% of cantharidin in combination with gentian violet. Why gentian violet? Mostly so one knows which of the lesions one has already painted. So it's a visually striking way to say, yep, okay, I got those 5, here's the next 7, let's do those, boom. And it's a standardized, delivery device, and it is found to be just as efficacious as the good old days when we were using cantharidin effectively. So dermatologists, at least the ones who are so far being quoted online about this new release, are quite excited, and I imagine we should be as well. And I imagine that it will not be long before many of us are able to have this product on our shelves to treat those numerous kids who just, oh, by the way, got some molluscum contagiosum going on, because, of course, it is a very common pediatric infectious disease. So if you don't have some yet, keep your eyes open for it. This is certainly not an advertisement or a plug, but just recognition that finally there is an FDA-approved standardized concentration which is safe, which is effective, and which is a wonderful, I think, resource that we can anticipate using more and more of for a very common pediatric infectious disease. Okay, last question is on leprosy. Oh my gosh, yes, Hansen's disease, leprosy. And the questioner is asking, with leprosy cases on the rise in the States and specifically in Florida, will we start to see more cases in other parts of the country? So, yeah, fantastic question. I think we may have all seen the media reports or if you're on an infectious disease listserv, the notice is there, that the Florida has just released data saying that they're having a mini surge of leprosy cases that actually is not 100% accurate, in that Florida has been having a fairly significant component of the United States annual cases there as well, and related or specifically found in 3 counties. So there's sort of a uniform presence, and they've just been sifting through data up until, I think most recently, 2005, and finding that there were clusters of cases. And now they're doing active case investigation and finding a continued number of cases, most especially from those 3 counties. And okay, great, wonderful, fantastic. Is leprosy a thing in the United States? Yeah, actually it is. And there have been, at least there are currently, an estimated 6,500 current patients in the States with a form or some form of leprosy. Most of those are in international immigrants, but especially from Mexico. So if we have patients who are U.S. natives with no travel history, their risk is somewhat lower. But let me back up for just a second. What is leprosy? What is, as it's otherwise been known as, Hansen's disease? And it is an infection primarily of skin and peripheral nerves caused by a non-tuberculous mycobacterium, that being Mycobacterium leprae, Leprae. And again, is noted that this infectious disease, to which many of us, by the way, are already immunologically protected, just by evolution, by genetics, by sharing, whatever, but those who are not may develop localized infectious plaques affecting peripheral nerves and skin, and also to a lesser extent nasal mucosa, the eyes, etc. This disease then is categorized into paucibacillary and multibacillary. Paucibacillary is sort of 1 or 2 lesions still expressing it, typically not with any major deformative appearance, typically stable lesions that do not progress. The multibacillary would be those patients with more than 3, I believe, lesions is the cutoff, and those are the ones who are considered lepromatous, or to have leprosy or active Hansen's disease. To acquire leprosy, though, requires prolonged close contact with someone who's known to be infected. And because most people who are known to be infected have very visible evidence of disease, they're relatively easy to recognize and to potentially provide contact isolation precautions for. So, but as noted again, the estimates are that 75% of humans in the world are already immunologically protected against this by antibody. Unclear how that developed. I'm not about to begin to hypothesize, but